It's not very often that I get to be the second Cathy B to speak. It's kind of new for me. All right, so I get to talk about survivorship care planning. How many in the room are familiar with the concept, at least, of survivorship care planning? Yeah, okay, that'll save me a minute right there. How many are familiar with the barriers to survivorship care planning in terms of the clinic setting? So one hand way up back there. Yeah, okay. All right. So, what I'm going to talk to you today, again, is about survivorship care planning. Sounds like most of you are familiar with the concept. Basically, it's a document given to a cancer survivor at the end of their treatment that talks about everything that happened before and everything that needs to happen in the future in terms of their care. Fewer people raise their hands in terms of knowledge of the barriers. I'm sure there are plenty of people in here who could talk at length about the barriers and seeing some heads nod. They're really difficult to put together. Honestly, they take hours sometimes to put together, and rarely can people be reimbursed for that time. So since there's no reimbursement, or at least difficult reimbursement, hospitals aren't just hiring someone to fill out a survivorship care plan. They're giving it to somebody who already has a job in the hospital to do survivorship care planning on top of their normal duties. Resources are already strapped in hospitals, and now the Commission on Cancer has come out with standards to say that everybody needs a care plan. So by 2019 now, everybody has to get a care plan within the hospitals. They actually changed the standard. When it first came out, 100% were supposed to get them by 2015, so last year. I work with hospitals all over the country on this, and not a single hospital had it figured out. They're really difficult to do and to create a process for. So because of that, you can probably imagine that our first strategy in the cancer plan, providing technical assistance, is sort of hard to do as well, right? Nobody knows how to do it, so how do you provide TA to tell people how to do it? So I want to give an example of something that the Michigan Cancer Coalition did. The Michigan Cancer Coalition prioritized survivorship care planning about 3 years ago and put together what they called a learning collaborative. So what we would call a work group, what we're talking about now. And their work group brought together hospitals. They brought together at least 2 clinicians from 22 hospitals across the state, in addition to bringing together cancer survivors, public health, and then also researchers in the field. And with that giant group of people, they said, what is our process as a state? What are we going to do? A lot of people think that survivorship care plans are all about picking the perfect template. There is no perfect template. So it's really more about process. And in terms of working together as a hospital, that's not always something that's easy to do because, honestly, hospitals are in competition. So there's not really a place for them to come together and say, okay, we share a patient. How are we going to deal with this? How are we going to collaborate, as the new standards say, to give them one care plan instead of 2 different care plans from 2 different places with 2 different pieces of information about their treatment? We need to be able to collaborate, and in my opinion, the coalition is the best way to do that collaboration because, honestly, we can come together in a non-competitive environment, bring together people from hospitals, and also bring together people from research and academia and public health and figure it out together as a state. So I think it's a really promising strategy if you look at it like that. In terms of the measures and the data, it's difficult. It's difficult to measure who's getting these things. So we know who should be getting them, right? We have 28 Commission on Cancer accredited facilities in the state. As of this year, 25% of eligible survivors from those facilities should be getting care plans. It'll go up to 50% next year, then 75, and then 100. So we can kind of calculate who should be getting them or how many, but that doesn't tell us anything, really, in terms of who's not getting them, who's actually getting them, etc. So what we've proposed to do in the cancer plan is add a field to the cancer registry to determine who's actually getting a survivorship care plan. So this would benefit us in multiple ways. First of all, we'll have population level data. We can look at this at a statewide level and say, who's getting it and who's not. Are only breast cancer survivors getting a care plan and no one else? Are only people in the Denver metro area getting them and no one else? We can look at it like that. but it's also a great way for hospitals to be able to track what they're doing. So they can see, did I meet my 25%? Did I meet my 50%? You know, it sounds like a simple equation, numerator divided by denominator, but nobody can figure out who their denominator is. And we don't have a steady way to track the numerator. So, honestly, we need something like this to be able to track this consistently across hospitals. And I think, again, working with a coalition to figure out how to ask those questions, how to work with hospitals to get that kind of information evaluated is really important. So, again, why should we prioritize this? I think this goes back to what I was saying about the Michigan situation. Hospitals urgently need something, and we have a place to provide it. We have the non-competitive environment where they can come together and we can sort of strategize together. Many coalition partners have also already been a part of this work. I know Betsy Risenbell's in the room, Andy Dwyer, I'd love to mention her, even though she wasn't able to make it today, she's been absolutely fabulous in this work. Linda Overholser as well has been active at a national level in survivorship care planning. Deborah Hess is here. I heard a couple other people say that they were here from hospitals and wanting to know about survivorship. So we already have people in the room that are ready to hit the ground running on this. And I think we can make fast progress with it. However, it's important to know that all of us lack the resources. So in terms of who can really take the lead, nobody has a grant that says we're going to figure this out as a state. So we all need to be able to contribute our resources together to make this happen. So in terms of pros and cons, I'll go through this quickly. Measurement, I think, is the biggest con. We don't have anything right now, but we can figure it out. In terms of pros, collective impact is just really important. Established need, like I said, this is urgent for hospitals. I've talked to dozens of hospitals who are talking about letting their accreditation go and no longer being an accredited cancer center just because of this one standard. So that's a problem, in my opinion. We have a ton of opportunities for partnership, and we can make a huge impact both now and in the future. If we get the processes set up right now to get survivorship care plans in the hands of patients, that will impact the survivors right now, and all of them, they get treated in the future that are eligible. So with that, Crystal gave me my stop sign well over a minute ago, so I'm going to stop. Any questions? Lots.
Hi. So once a survivor has a plan, I mean, that's great, and you know, you have a 5-year plan. How does the survivor or a family member know to act on that plan? So what happens? How do, you know, 2 years from now, how do I know what I'm supposed to do as far as a survivorship goes?
So a component of the survivorship care plan is a 5-year plan for follow-up. So it's meant to be given at the end of treatment, and then it tracks everything that needs to happen for that 5-year surveillance period. That's a part of it. But also, the new 2016 standards do specify that a plan can't just be sent in the mail, and it can't be just emailed to someone. It has to be delivered in a conversation. So then it becomes a conversation, an active conversation with a clinician, where the clinician is able to say, this is what we're going to do, here's our plan, and then check in on it. Every time you have a 3-year or 3-month or a 6-month check-in appointment, check in on that plan.
So then the issuing party is responsible for that 5-year plan, basically?
Basically, yeah, but also it's meant to be sent to the PCP, and so the PCP as well would be more in the loop than they have been in the past, and also able to check in on the patient and see what's going on. So, Janice?
Has there been any movement toward this collaborative of getting hospitals and providers involved in developing a comprehensive plan that all the clinics can use here in Colorado now? You talked about the collaborative that developed in Michigan. Is there something moving in that direction now here?
So I'm going to, Sarah reminded me earlier to repeat the question. So the question was, do we have a collaborative similar to Michigan's collaborative? Right now, no. I would argue that we should prioritize this as a coalition so that we can make that happen. We do have the Quality of Life Task Force, and this has been an area of focus for the task force, but we haven't been able to make as much progress as I personally would like, or many people in the room would like, because it just hasn't, it's been shared among so many different things. So that's why I think it should be a priority. I think we have the opportunity to do it right now. Dennis, I thought I already answered your question.
Maybe. You talked about the measure of how many people get this and the difficulties with doing that. But that's not really what we want to accomplish, right? We want to make sure that these are high quality and that they have an impact on something, on quality of life in some way. So what's the next step? Once we know that people are actually doing it, how do we measure whether it's had an impact?
Absolutely. Awesome that you asked that. So part of what Michigan did with their collaborative and part of the reason that they had public health at the table was so that they could evaluate while they were going through the process. So while the hospitals were all coordinating with each other in terms of lessons learned and what's a best practice and things like that and sort of figuring out the logistics, the public health folks were able to come in and the researchers were able to come in and say, okay, how are we going to track this? How are we going to evaluate impact? And then embed the tools that they came up with in all of those 22 hospitals that they worked with, so they are able to see the long-term impact throughout the state. So that's another reason to have this collaborative, because if hospitals do it by themselves, that's great, but we won't all be evaluating in the same way. And I think that's the way we get enough data to really be able to show long-term progress. So many hands. Tony, I see. Nikki.
Hi. I do want to bring up some of the arguments against survivorship care plans. There's been some articles that have talked about outcomes related to better quality of life for survivors. Especially, I think it was Grunfeld, the impact of event score was used and they didn't see any differences. And so I'm just wondering, measures related to that, if people have found that there is no difference in quality of life.
Yeah, absolutely. There have been several randomized controlled trials that have not found differences in quality of life from receipt of a care plan. Honestly, I'm not that surprised by that, because is getting a packet of information this thick going to make your life better? I don't know. The point is that we want people to come back for their follow-up appointments, and that's something that hasn't been tracked in a randomized controlled trial. Are people coming back for their follow-up appointments? Are they catching recurrences? Are they seeking resources that then do impact their quality of life, but later on? Honestly, the tools that they used in those studies have been highly scrutinized, just because the way they study it is very different than what you would actually expect in terms of an impact. And I think that could be argued all day long. I'm sure it could. But it's true, the randomized controlled trials don't show a ton of evidence in the specific area of quality of life. But the fact of the matter is hospitals still have to do it and patients still want these plans. In fact, I was talking to Deborah yesterday, and she was saying for the first time, patients are actually coming to me and demanding a care plan. They want information. And I've talked to people about this that are survivors, from 10 years back, and they say, what? I never got a care plan, and they're angry about it. So the fact of the matter is, whether or not we're able to measure a specific, quality of life indicator or not, people want these plans, and I think the people that have been involved with patients and given them the plans will tell you that it does make an impact. We just don't have the tools to measure it.
I wanted to say that Penrose has been giving survivorship care plans to their patients for many years through the National Community Cancer Center program grant that we had. We actually piloted these programs, and one of the things that was beneficial was having a physician's liaison who took the plans individually to the physician's office and told them about the plan, so discuss the plan with the physician's office. But that was when we did have a designated person to do that. I'm not in that business, so I don't know exactly what happened after the grant was gone, but I do still believe that the majority of our patients who are navigated end up with a survivorship care plan.
All right, thanks.